Good morning, everyone. Thank you for, or good morning from Ottawa. It's good evening from Manila and good afternoon from Geneva today. Thank you for joining the call today. We're talking about universal health coverage and the private sector. And we are having two really interesting speakers. Thank you for joining us. Celine Garfin is joining us from the Philippines, and she will be giving us an example of how health insurance schemes are connected to tuberculosis. So we're starting off with a peek into the practice of the TB package linked to health insurance schemes. And she will give us some of the positive experiences and the complications around doing that. And after that, we're really pleased that Dave Clarke from WHO will be joining us to talk about the roadmap that they are outlining at the moment related to universal health coverage and the private sector. And he'll guide us through some of the main components, and are looking forward to hearing from him and later on from you. We will be recording this whole webinar for the next hour. Anyone who has any questions, you can, or clarifications, please feel free to use the chat function during the call. You can pose any questions that you have in the chat function, and I'll make sure that we will address them either immediately after the talk or in the end when we have a little bit of time for questions. So without further ado, I'm going to give Celine the floor, and I'm going to share the slides from my computer. I'm trying at least. And here we go. Celine, do you wanna go ahead?
Yes. So good evening, everyone from the Philippines. So I'm here to share our experience on our TB package. So it's called the PhilHealth TB Outpatient Package. It started in 2002, and it is a case rate benefit for each outpatient TB case. So it is for new and relapsed TB cases initially. But later, this was expanded to include all the retreatment TB cases. So the amount to be provided is about $90. So the benefit would include a consultation, TB medicines, and the necessary diagnostic services. And this payment is given to the accredited facility and not to the patient. But before the accreditation of the facility, they should be certified by the Department of Health and the Philippine Coalition Against Tuberculosis. So this is an organization of both government and private sector. Next slide, please. So this is our accomplishment since 2015. So accredited facilities for the public sector is about 2,000, but this is only 75% now of the total rural health units or the primary care services or rural health units in the country. For the private, it's only 107. We don't have the denominator for the private facilities. For the claims, it's low for 2019. Actually, it's decreasing since 2017, since this is the time that the PhilHealth has also introduced the electronic claims. And I think this would be a transition period for the different facilities. Maybe for the 2019, it's really very low because the data is not yet complete, since this was gathered January of this year. For the utilization rate, the number of claims, so it's about 9,000 for the intensive case for the public sector. And then for the continuation phase, it's about 5,000. So the package is provided for the intensive phase and for the continuation phase. For the private, it's 1,500 and nearly 1,000 for the continuation phase. So it means that the full package is not being given or reimbursed by the facility. And in terms of number of cases, this is very, very low because we are finding about 300,000 TB cases. Next slide, please. So what's the benefit of the collaboration with the health insurance? So this really helped us in the engagement of the private sector since the package was provided as an incentive for the private sector to provide the service or to refer cases to the DOTS facility. So if you are a private providing facility, you would be given 80 US dollars. If you would only refer cases, then you will be provided 21 US dollars. For the public sector, because of the sharing of the reimbursement, this is also an incentive for them. For the facility to be reimbursed, we should note that the treatment of the patient should be based on the guidelines of the program, and the case is also reported to the program since for them to be reimbursed, it is a requirement that the official TB treatment card with the TB case number should be given. Then part of the package payment was also used to augment the procurement of drugs and laboratory supplies when stocks from the Department of Health are delayed or are not adequate. Next slide, please. Okay, the challenges are first is ensuring that payments are given on time and are provided to the health workers as well as to the referring physician. Since the risk really is the process of the reimbursement is cumbersome, so that would delay the provision of the payment. At the same time, because of the delay, the health workers are not motivated to submit their claims. Next, please. So with the signing of the Universal Healthcare Law just last year, PhilHealth will pay for the health services identified as individual-based, while DOH will pay for the population-based services. For TB, it will be individual-based, but there will be a transition period. So the plan now of PhilHealth is they will consolidate all their primary care benefit, and this will be called the PhilHealth Consulta, and this will be paid through capitation. So for each case, there would be about 15 US dollars. Then the TB DOTS package, the existing TB DOTS package will be integrated into the Consulta primary care benefit package. So this is now the proposed. Next slide, please. Next slide. So this is the proposed package for the drug-sensitive TB. So PhilHealth Consulta or the primary care package would include consultation, chest x-ray, direct sputum smear microscopy for diagnosis, and the post-treatment monitoring consultation. So before, in the original PhilHealth package, a chest x-ray was not specifically uh, written that it should be part of the package. So it means screening will now be part of the benefit package. For the gene expert, this is still for discussion because the price of the gene expert is high. And if we know the package or the primary care package would only be $15. What would still continue for the TB DOTS package would be drugs, TB drugs and consultation during treatment, and the direct sputum smear microscopy during the monitoring of the treatment. And for now, the drug-resistant TB package will be considered as a population-based and will be provided by the Department of Health. So next slide, please. So what were the key factors for the program and the social health insurance collaboration? So we have the policies in place. So first, we have the executive order number 187. So this was in 2003, and we call this the Comprehensive and Unified Policy for TB Control in the Philippines. So it's a group of organizations, 17 government organizations and 5 private organizations that agreed to align policies with the National TB Control Program. So they will follow, no, the policies of the program for screening, diagnosis, and treatment. And this includes the PhilHealth TB benefit package as well as the TB benefit policy for the Social Security Service, Government Social Insurance Service, and the Employers' Compensation Commission Service. Then aside from that, we have the Republic Act 10767. So this is the Comprehensive TB Elimination Plan Act, wherein there would be a national coordinating committee which will serve as the national TB program's arm in strengthening and supporting the nationwide capacity for program operations and bridging the collaborative efforts between the public and the private sector. So PhilHealth is part of this committee, and this is already functional, and we already had 4 meetings, and part of that meeting is the different organizations will provide updates on what they will contribute to the program. Actually, we're also now designing what would be their accountability for the program as part of the multi-sectoral action framework, or the MAF of the DOH. So as a sharing for the different program managers, it would be best for the program to be involved in the designing of the package from planning to execution, so that we can inform the social insurance what should be part of the package. So this is from the Philippines. Thank you.
Thank you very much, Celine, for this comprehensive view into how it actually works at the country level. It was really useful to hear you outline how the steps since 2002 actually have already been put forward into the scheme and now rolling into the universal health coverage scheme. I'm just saying again that anyone who has any questions, please, or asks for clarification, please feel free to use the chat function during any talks, and I will pick up any questions that you might have to Celine at the end. We would now like to move on to listen to David from the World Health Organization, and he will talk us through the new roadmap, the framework that they are developing on the UHC and the private sector. David, the floor is yours.
Thank you, Petra. Can you see the PowerPoint?
Yes, we can.
Excellent. Thank you very much. So thanks, Petra. Thanks, everybody, for taking part today. And in some ways, the work that we're doing has been inspired by the work that's been done in the TB area and the private sector. For a long time, WHO has worked on the private sector topic in I guess in a very fragmented fashion. Some of the program areas have done some very interesting work with the private sector, recognizing that unless we work constructively with the private sector, we're not going to get to some of the health outcomes that the government's seeking to achieve. And for us, the UHC agenda is actually opened a door to do more work in this space. And I should just start by saying that UHC is very much a health systems approach. It's about making sure that all people have access to the services they need of sufficient quality and without suffering financial hardship. So it very much focuses on access to health services across the health system, not just to different program areas, but to health services as a whole. And with that in mind, and with the experience of some of the program areas working on the private sector topic, about 2 years ago, we started to do some work to think about how we could help countries to work better with the private sector to help them to reach their UHC goals. Now, this is super important because if you have a look, I mean, many of the people in the teleconference will know that in most countries of the world, over half the health services are being provided by the private sector. So if we are going as WHO to work towards our triple billion goals, 1 billion more people having universal health coverage, it's a bit difficult for us to do that work unless we are helping member states to better work with the private sector. Otherwise, we're not going to be going anywhere near the triple billion goals. So that's kind of like the background for why we're doing this work. I guess the other reason we're doing this work is that we recognise, and I'm in the governance department, that if we're going to be giving our member states the best advice on how to govern their health systems, we have to be telling them how they can govern their health systems as they are. So these health systems are no longer predominantly public systems. So we no longer have ministries of health predominantly providing services, or ministries of health and the NGO sector. We have mixed health systems. So for WHO, that means changing our historical focus on working to support the governance of public systems to a focus on the governance of mixed health systems. So on this first slide, this is the challenge that we set ourselves when we started this work. And the challenge is, how can we catalyze quality healthcare service delivery so it's available to everybody in the health system, wherever they may seek it. Now, given what I said before about the prevalence of the private sector, we realized pretty much very early on that we had to work with the private sector to help reach this goal. And it's about making sure that the entire population has access to the right healthcare at the right time in the right place. It's about making sure that health systems deliver good health, that they're responsive to the expectations and needs of patients and the population and financially viable, that governments can successfully deliver stewardship of the health system. People often say the private sector will not steward itself because they won't. They're there to make a profit. It's not their job to meet the health system goals that governments have signed up to. It's government's job. So it's very much our focus on to help governments to exercise its stewardship role over all of the participants in health systems. And also, from the WHO perspective, we work to support our member states to make more informed decisions about the private sector. We're very conscious that for a long time, a lot of the conversation about the private sector in health has been very based on rhetoric rather than on evidence and based on good decision making. So a lot of the focus of the work that we're doing is based on trying to do something about those two things. So just to turn to this next slide. So we have come up with a theory of change for this work. And our theory of change is that if we're going to achieve universal health coverage at the top of this slide, we really need to bring together the public and the private sector. So we need to build understanding of the role of the private sector in the health system. We need to come up with and deliver on strategy. So we need to have specific strategies and policies about the private sector. We need to enable stakeholders to work together to achieve UHC, that's public and private stakeholders.
Dave, can you enlarge the next slide, please, for us?
This one here?
The second one you're talking about?
Yes.
Okay, here we go.
Oh, sorry, that's better. Yeah, sorry about that. So, yeah, so we need to foster relations between the two systems. We very much need to align structures. We're not just talking about a public system anymore, we're talking about a mixed system. And fundamentally, we need to nurture trust between the two, between the public and the private. You often hear that there's a lack of trust between the public and the private sector in relation to systems. So this is something that we put a lot of effort into thinking about how we can do that. And moving on to how, in practice, we are thinking about how we should do that. So because I work in the governance team, we're very much focused on a set of governance behaviours that we think need to be well developed and implemented by each country to enable them to work best with the private sector. And if you look at this cog diagram, you'll see that it very much focuses on what I've been saying all along through this presentation, that it's about managing mixed systems. So we have the public service delivery on the right-hand side and the private sector service delivery on the left-hand side. And bringing this all together is a series of governance behaviours. Delivering strategy, aligning structures, nurturing trust, fostering relations, building understanding, enabling stakeholders. This isn't the one-size-fits-all model for all health systems. We're very much conscious that different countries will be in different states of maturity in their health systems and have different ideas about the role of the private sector. But this is just a framework that we've come up with that we think applies to all health systems and can be adapted to all health systems to help governments to better manage the whole system. Now, just turning to some of the key ideas in the roadmap. First, the first idea is that we need to build better understanding of the role of the private sector in the health system. So for that, we need a couple of things. We need to reach agreements between different groups on what the role of the private sector should be. And that agreement should be reflected in government's national health policies and plans. We've had a bit of a look at the national health policies and plans that are in place already. And there aren't that many national health policies and plans that have explicit provisions about the private sector. And our position is they should. So that's one of the key areas that we think needs to be addressed. And it needs to be addressed by bringing together different stakeholders in the system so they can reach consensus on what the role of the private sector should be. The other thing about building understanding is having a better picture of what the private sector actually looks like in a country. And quite often you hear that countries don't have a good sense of what the private sector looks like in their particular country. So we've been doing alongside the roadmap, we've had 2 sets of consultancies running to help with this. So the first one looked at health data from 65 of our member states to look at the private sector mix in those countries. So we now have up-to-date information about what private sector looks like in these countries and who's seeking care in the private sector in these countries. And it will come as no surprise to anybody that the general picture is that over nearly half of health service delivery across the world is private, not public. So we very much recognize that we do need to work with the public sector. The private sector. The second consultancy that we've had running is we are also very conscious that the amount of information about the private sector that exists in health systems tends to be really patchy. And governments can't really manage their system unless they know what's going on. And if they don't know what's going on in the private sector, it's very difficult for them to exercise their stewardship function. So the other consultancy that we've had running to help build understanding is to come up with some new metrics to help governments to assess what they should be measuring about the private sector. And we think that's really important, that we have metrics which don't just look at the public sector, but also look at the private sector, disaggregate health service delivery by public and private. Now, then the next thing I wanted the next governance behavior I wanted to talk about is the idea of delivering strategy. And this kind of leads on from the building understanding governance behavior. So we very much recognize that health system decision makers really need to know where how they're going to get to UHC and other health goals. And to do that, they need to have a better understanding of the role that the private sector should be playing in a health system. So this is going back to the previous slide. This is why it's really important that we have explicit provisions in national health policies, or indeed separate policies, which set out the government's strategies for working with the private sector quite explicitly. The next governance behavior I wanted to talk about is the idea of enabling stakeholders. Because we're talking about mixed health systems, we think that the institutional framework that operates in health systems needs to recognize the autonomy of different actors and creates decision-making space to allow them to work together. So that means designing and deploying various tools, powers and incentives and sanctions. So that might be regulatory tools or financial tools to make sure that stakeholders and others are working together towards the health system objectives that we need, and that we prevent behavior which is a threat to those objectives. So this is where regulation and financial incentives comes in, and this enabling stakeholders governance behavior. The next thing that I wanted to talk about is this idea of fostering relations. So we are very conscious that a top-down regulatory approach isn't necessarily going to work in most of the countries that we work in. Most of the countries, the middle-income countries and the low-income countries, don't have strong regulatory capacity. And we're also seeing developments in the health system where you're seeing very sophisticated digital solutions coming online, which are incredibly difficult to regulate, even for countries with more regulatory capacity. So we really do need to think about different ways of working with the private sector to achieve the health outcomes that we want. So we're very much, for this governance behaviour, we're very much focused on building partnerships and coalitions to achieve positive change in health systems, to get to the UHC goals that we're after, for access, quality and financial protection. So this is where we would do work on things like public-private dialogue and coordination mechanisms at global, regional level and at country level. And it's also where we would want to work with our development partners and donors to make sure that the work that's going on in particular countries on the private sector is well aligned. The next governance behaviour I wanted to talk about is the aligning structures governance behaviour. And this is about making sure that all relevant stakeholder groups are structured and organised in a way that works actively and aligns well with national health policy. This is super important. It means that in the health system, all of the different structures, public, private, private for profit, civil society, not for profit, must reflect and deliver on the policies that have been established by government. So the organisation, structures, contract arrangements in the health system all need to be designed to make sure that they align well with the government's national health policy goals, particularly those in relation to the private sector. The last governance behaviour I wanted to talk about is the idea of nurturing trust. An issue that always comes up with the topic of the private sector is the question of accountability. Accountability of the private sector for the provision of the services in health systems. This is, I guess, also where the topic of the lack of trust of the private sector often comes up as well. So we think that we need to put a lot of emphasis on accountability of the private sector, but also the public sector in systems to make sure that not only patients and end users trust the system, but also that the public sector and the private sector are working together in an environment which is based on trust. So we're very much here focused on governance behaviours and tools, including a mix of powers, incentives and sanctions, which are intended to improve accountability and dialogue between the public and the private sector and the end user, the patient. So that's basically the governance behaviours. So, but what does all this mean at a country level? We're thinking about, as we're working on the roadmap, we're thinking about how it can be deployed at the country level alongside the work that WHO is already doing on governance. Well, for us, it fits into a framework that looks like this. First of all, we're very much focused on the government's key health priorities. So we're not trying to impose a set framework or a cut and paste model onto countries. First and foremost, we start with where countries are and what they're trying to achieve in their health systems. The second thing that we think is really, really important is to identify the role the private sector is currently playing in that country and its impact, good and bad, and to look for areas where we could use the private sector more efficiently to achieve health system goals, but also to stop behaviour which is negatively impacting on health system goals. And that takes us to the next idea, that we want to support governments to know how to intervene, what tools and approaches that they should be using to address this topic. And what we hear time and time again is that many countries know that they need to do more in this area, but they say they don't know how to do it. So we're going to do some more work once the roadmap is finished on this topic to better help countries to understand what to do. And at the same time, carry out more research and evaluation of the effectiveness of different tools and approaches. Because at the moment, the evidence base around working with the private sector is a bit thin. The next thing that WHO in particular would be doing would be supporting member states to implement these tools and processes. we recognize that this is actually something that's going to require in some cases, quite intensive support. And that's because these things are not set and forget projects. Managing the private sector over a long period requires governments to build capacity to work with the private sector, to learn how to do it, to look at how they can do it in their particular context. So it's very important that we support countries in this endeavour. And then the last thing, and this is super important, because even though there's been a lot of work done in the private sector over a long period of time, we think we need to do a lot better to monitor and evaluate the approaches that are actually being used on a day-to-day basis in health systems. Because again, we hear that there isn't actually that much evidence out there about what works and what doesn't work. The evidence base in relation to the private sector in health is actually quite sparse. So we think there's a lot more work to be done on the concrete things that can be done to better manage the private sector in health. So with all of this in mind, we've come up with a results framework to demonstrate how we think the various objectives and outputs that we want to deliver as part of this project will play out. So on the left-hand side of this diagram, and I'm sorry the text is very small, but we'll make this diagram available to people afterwards. We have a series of objectives and outputs that we want to achieve from this work. So just reading one of them at the top so people can understand, get a bit of a sense of what I'm talking about. Number one is to promote commitment and ownership of the objectives for health system governance interventions and the roles of different stakeholders in achieving these objectives for UHC. And to do that, we think we need to have much better understanding and come to a shared understanding and appreciation of the need for improved health system governance through the collection and analysis of data that allows the alignment of priorities for actions. This is going back to this slide at the start about the importance of better data. And all of this is intended to feed through to our mission, which is to facilitate a new way of governing mixed health systems by building consensus around the means and strategies of engaging the private sector in health service delivery, and ultimately to get better health services for patients and consumers in health systems. So with all of this in mind, we have come up with this. This is just a snapshot of the roadmap. There is a much longer document, a roadmap which has been designed by an expert advisory committee that works with us on the private sector. So this roadmap is available on the WHO website, and we're currently consulting on the roadmap. So that's draft 0 of the roadmap, and consultation is going to close on the 31st of March. So you have plenty of time to put in comments if you want. We very much welcome comments, and we very much welcome dialogue with people who want to make comments on the roadmap. Once we have the comments and we've thought about what they mean for the roadmap as it currently is drafted, we will definitely be doing some more work on the roadmap. Alongside the work on the roadmap, we have a series of consultancies. I've mentioned the 2 consultancies about data, but we also have a series of consultancies about other topics that relate to the roadmap. So for example, we have a consultancy about accountability. We have a consultancy about a set of principles to guide member states' decision-making about terms of engagement with the private sector. And all of these different consultancies, once they finish, will be used to build more detail into the roadmap. And then once we have the roadmap finished, we'll be thinking about implementation. So the first 2 quarters of this year, we'll be working to finish the roadmap. And then the 3rd and 4th quarter will be into implementation mode to work out how we can implement the roadmap across different countries. So I guess that's in a nutshell what WHO is working on at the moment. As I said at the start, the focus is on managing the private sector at the health system level. We recognise and applaud the excellent work that's been done by our program colleagues, and I'm very cognizant of the great work that's been done in the TB space over quite a long period, really. But we think we're at the point in time where we shouldn't be talking about the private sector in TB, or the private sector in child health, or the private sector in NCDs. We should be talking about the private sector in health systems, and how we can better utilize the private sector to achieve this goal of universal health coverage, which is, after all, the driving goal of all health systems. It's been accepted by all member states, recently reaffirmed by member states at the UN high-level meeting on UHC last year. So we think that it's timely that we use the UHC agenda as the basis for better management of mixed health systems in relation to the private sector. So with that, I will stop, and I will be very happy to continue the dialogue and answer any questions.
Thank you, Dave.
Thank you, David. Madhu, did you want to say something or comment?
Yes. Thank you, Dave. That was extremely helpful. Now, as much as you were kind to highlight the progress made in TB, I just want to amplify what you said at the very end, that we are kind of approaching this disease by disease. And even while working with the private.
Hello?
Madhu? I think we might have
really
lost Madhu.
Awkward and odd that we improve quality of TB care alone, for example, while we leave everything else untouched, right? So we have learned that you can improve TB care, but they still abuse antibiotics very widely, and we've not been able to do anything about it in our PPM programs. So it does make us worried that this TB alone PPM will soon reach its limits, because people present with multiple problems, and GPs don't only take care of TB, they take care of a variety of different conditions.
Yes.
Over to you, Petra.
Dave, did you want to comment on that?
No, I agree with all the things that Madhu said. That really we want to encourage integrated care. We don't want to encourage vertical care, and it's really, I mean, it's that care doesn't occur in little silos. I mean, as Madhu said, particularly in middle income and low income countries, GPs and other health providers are actually providing a package of services. They're not just providing TB services, malaria services, or NCD services. They're providing a package of services. Mm-hmm. And it's really, I mean, there's the boundaries between these different services and different programs blur quite considerably. So we really do need to look at this from a health system level rather than just a program level.
I can only kind of summarize that shortly, because I think it's a very wide spectrum that we're talking about in this this call, because we're having Celine bringing forward how the TB program has integrated or has matched itself with the social health insurance schemes, and bridging it to the universal health coverage schemes that in the Philippines. So I think the work from both sides, where I'm pleased to hear that you're taking concrete country examples and concrete program examples to kind of filter out where maybe the challenges are in mapping out the private sector. So it is an extremely wide spectrum that we're talking about in this call, and integrated care or quality of care is obviously where we all have the final aim. And I think we have one question that came in beforehand that I already let you know with. From the patient perspective, we have some active TB survivors that are really keen to be part of every phase of not just the care package and the quality of care, but also the planning and the policies. Sure. And for the question that came forward in the framework and the development of your roadmap, how are patients having voices in what you are currently outlining?
Well, it's very much part of our thinking, because when we did work on the roadmap, we're not just thinking about the SDG goals that relate to universal health coverage and the goals of access, quality, and financial protection, we are thinking also about the cross-cutting drivers that help with all the SDGs. And that includes accountable institutions and better participation. So very much our work is very much informed by the need to improve the voice of patients and other stakeholders in the health system to improve participation in health systems. And I should also point out that the UHC quality objective isn't just a technical quality objective. WHO's view on health system quality is that it is not just a technical thing. Quality also has the patient-centered perspective. So it's also about making sure that people expectations about their health services are met by providers in health systems. So we very much see patients being at the center of this work. And in fact, on the advisory group that works on this topic and is helping with the roadmap, we do have a person who is a patient advocate and who works with patient groups, because we recognized very early on that it was very important for us to make sure that patient perspectives were taken into account in the design of this roadmap. And we would very much like to hear from patient groups as part of the consultation process to make sure that we are getting this right and make sure that we do understand very well how we put patients at the center of this work.
Thank you. I'm looking at the current participants. I'm not having many questions on our chat function.
I have a question. Dave, in TB, when we begin working with private providers, often we find that the baseline quality of TB care is rather low and really variable. But if we stick with them for a year, 2 years, 3 years sometimes, over a period of time, by working closely with them and by offering a whole bunch of incentives and services to the patients, we do see the quality improves and treatment completion rates increase and diagnostic rates improve. But my big worry is if one is not patient in private provider engagement, and if one sees the low quality of care at the outset and use that to basically say, this is a bad idea because private sector is low quality and therefore public sector is the way to go. I'm just trying to understand what in this roadmap, do we have anything in it which says that it is not an instantaneous process to improve quality in the private sector, because you might start off at a very low level and it is a struggle actually to bring it to a level that we would consider acceptable. And by the same token, there is no guarantees that the public sector quality is dramatically better either, right? So I think this is what a lot of people kind of say, oh, private sector is low quality, therefore public sector is the way to go, without really completing the whole picture to say public sector could also be poor quality. So quality improvement needs to happen in both sectors, and it takes time to improve quality in both sectors.
It does. It's a long-term process. I mean, before I came to WHO, my first job, I was in the Ministry of Health in New Zealand. And when I was there, it was at a time when we were transferring from a very centralized state-run system where the state ran all the hospitals to a system based on contracting where the state was contracting for services and there was far more private provision. So one of the first things that happened was to look at how we could improve quality, not just in the private system, but across the public system as well. And it is a long-term endeavor. And the roadmap doesn't explicitly deal with it, but underneath it certainly does. I mean, if you think about the focus on better data and better understanding what's going on in the health system, quality is very much to the fore in relation to that activity. Also in relation to trying to improve the quality of services, both in the public and the private system. Again, it's not explicitly mentioned, but again, it's something that we're thinking about. We very much are aware that we're talking about working with countries to strengthen their health systems over a long period of time. And we're also very, very much aware that sometimes we're going to get things wrong, that we're going to have to use trial and error to try and come up with the best solutions for particular countries. And that's why we think there's a need to provide countries with long-term support to help with this process. It's not something that can be done overnight. And we're very cognizant that sometimes, particularly with the vertical programs, we'll have projects where people fund a project for a set period of time. And the funding goes, project falls over. So we're in it for the long haul. I mean, if we are going to achieve the Sustainable Development Goals, if we are going to support countries to have resilient health systems, then we need to support them over a long period of time to build into their systems things like quality, things like better accountability. It's not something that's going to happen overnight. So though it's not explicitly mentioned in the roadmap, it is definitely at the forefront of our mind as we go into the next phase of the roadmap and think also about implementation.
Yeah, I just want to end by saying that premature impact evaluation of public-private mixed programs could well mean that donors will abandon private sector engagement, because in the short term, they may not see a dramatic improvement that they're looking for. And if one isn't patient enough to wait, then the impact evaluation could actually be harmful for engagement is my concern. Yeah,
absolutely, I agree.
Thank you.
Thank you both. I think I would like to give the floor to Celine, who also would like to comment. And I have a question actually for both of you, or mostly for Celine, but it is, how is the government of the Philippines funding the capacitation program for public and private health centers? And what are the plans for sustainability? So this in a way ties into the conversation that you were both having about longer term support to the private and public programs on quality. Celine, would you like to comment?
Yes, for the quality, I'd like to say that with the public-private engagement, the quality for the public sector is also being, in a way, because of the feedback of the private sector, we need to improve the quality of the services of the public sector. It's not just saying that the quality of the services for the private is not good or from the public is not good, but with both, with the collaboration of the two organizations, everybody is on their toes to ensure that the services are really provided are of good quality. An example is sometimes the private sector will inform me that, oh, how come that our when we refer our patient, they are not given the, or like for example, if they're referred for the expert examination, they are not being provided by the public sector. So we call the attention of the private sector. So that is a feedback that helps us monitor on the quality of the services of the public sector. So I'd like to answer the question on the funding. So for the capitation program, so this is provided by the health insurance. So this capitation is given to accredited facilities. And when we, if once you are accredited, then you will be given the reimbursement. So for the sustainability, part of the budget that we have now for the different health services, including TB, is the syntax. Part of the syntax is given also to DOH, and part of that is for the TB program as a priority program of the Department of Health.
Thank you, Celine. I think there's one follow-up question linked to this. It is, what is currently being done to manage the challenges, especially the delays in payments that providers are facing? And the comment is, I believe that many low middle income countries can learn from what the Philippines is doing.
Okay, so the problem is with the electronic claims. So PhilHealth is now improving and are having a dialogue with the different health facilities so that they can improve the reimbursement. So that's something that they're really discussing on how do they facilitate the payment. And as part of the National Coordinating Committee meetings that we're having, PhilHealth is 10 o'clock sharing with us the plans on how to address the different challenges. So they have plans to improve the information system.
Wonderful. Thank you for that. I'm just looking around. I don't see any further questions in the chat function. Is there anyone who would like to comment on the debate that's happening currently, or put an opinion forward, or make a comment?
I have one comment and question for both Dave and Celine. So Celine, how have you overcome, first of all, is there a big distrust or mistrust between the public and private sectors in Philippines? Because I find that to be an overwhelming narrative in India, where I cannot say a word about private sector in India without somebody pointing out to me that that will come at the cost of weakening the Indian public health system. Like this constant tension, or private in India is immediately equated to being dangerous, exploitative, unethical bunch of people. So this is partly, I think, what is remarkable about India's success with the TBPPM, because for years the mistrust was so bad that nothing ever got done. I mean, PPM was there on the books, but nothing actually happened on the ground. But something managed to break there, but I don't think it has broken outside of the TB space within India. There is still a lot of mistrust about privatization of health services. So I just wanted to know from Celine, what is the dynamic between public and private in Philippines? And then ask Dave that this nurture trust in the framework, I really think is absolutely fundamental. And even to get started, a certain amount of trust needs to be there. I'm not sure what is the right mechanism to build or nurture trust, but it seems like this could be like the Achilles heel of private provider engagement, because if there is no trust, then each of us is shouting at each other from different poles, and there seems to be no meeting ground for all of us.
Yes, Madhu, there's really distrust of the public sector as well as for the private sector with the private sector. So what we do is we involve the TB champions. So those that are well-known pulmonologists are part of the program. We engage them. And what is good is we have the Philippine Coalition Against Tuberculosis. So it's a group of 67 organizations, mostly professional societies, that are helping the TB program. So for us to build the trust, I think that aside from the trust, there should also be respect. For the private sector, we trust, we respect that they are there with profit, for profit, and for the private sector to respect the public sector that they have a lot of patients, and they should also understand that and should respect and trust the public sector. So it's really difficult, but I think what is important is that we have a continuous dialogue for both the public and private sector. We need to provide feedback, not to each other.
Yeah, absolutely. It's definitely a common thread across the work that we do. And I think what's really interesting is the private sector understands this very well. Yeah. So later in the week, I'm giving another talk to a different group. I'm giving a talk to a group of private sector people who work as part of the UHC 2030 private sector constituency who have committed to work towards UHC. And one of the things that they're very well aware of is the fact that the private sector is not well trusted by the public sector. That we absolutely have to do something about that. We need to move beyond mudslinging and rhetoric and look at how we can actually get these two systems to work together. Otherwise, we're not going to achieve UHC. So, and we think that the different governance behaviours that we outline in the roadmap cumulatively should help us get there. But what's really important, we think, is that there be agreed information sharing and agreed metrics to measure the respective contributions of the public and the private system, to make sure that we can actually see that people are doing what they say they're going to be doing, and we can monitor it and show that it's actually working. Because at the moment, a lot of the discussion still is around rhetoric and ideology rather than facts and figures and information about whether or not health service is being improved. So it's really, really important that we have better data about that so we can actually show the impact that we want to achieve from this work.
Thank you. Thank you, all of you. And I think sort of a common thread is also having people talk to each other. And if you have good people and good champions on things that work within the private system or in the public system, I mean, those are the drivers of change often. So building on that, it's almost 10 o'clock. I'm really happy that we had a really good group of people talking to us today about this really complicated subject that has so many aspects to it. And thank you, Celine, for bringing the TB community around and level them up on what you're doing in the Philippines. Some really great examples. And Dave, thank you for the very inspiring thoughts of the framework and the roadmap, and bringing some really philosophical topics in a concrete way forward to us. I think it will inspire many people in the TB community that are struggling to find their ways in working with the private sector on a daily basis, to have some new lenses to look at things. So thank you for sharing your ideas. And thanks everyone who joined us today. Thank you for your comments beforehand. Thank you for your comments today during the webinar. And the discussion forum will be open afterwards too. So if you do have any questions after maybe viewing our version that will be online, if you didn't have a chance to be with us live, please feel free to look on our site. You can review this, you can listen to this in audio, and you can comment. If there are any specific questions, we'll tap into our experts to see if we can find answers for you. As Dave also outlined, there's a questionnaire where you can provide your comments. We will post the link again on our site too, so feel free to be part of the debate and the dialogue. And we are looking forward to our next webinar, which will be in the beginning of March. Look out for details. We will have another webinar around this topic. William Wells will be talking to us in the first week of June, on the 2nd of June, where we'll be going a little bit more into examples of specifically how the TB community is looking at social health insurance schemes. So look out for that. If you're interested in this topic, there will be more in the upcoming months. Thanks everyone. Have a beautiful rest of the evening.
Thank you, Celine. Thank you, David. Thank you, Petra.
Thanks, Madhu. Thanks for joining, everyone. See you next time.
Thanks all.
Bye.
Bye. Bye-bye.
Bye.